From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello, and welcome to our listeners around the world. You're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. This is Ilana Richman. I'm an editorial fellow at JAMA Internal Medicine and guest host of today's podcast. Before we begin, I want to note that the topic of today's podcast is physician suicide. It's a difficult subject for any of us, and I want to be sure that those listening know what to expect. If you or someone you know needs help, please reach out to someone. In the US, you can call, text, or chat 988, the Suicide and Crisis Lifeline. So in this week's issue of JAMA Internal Medicine, John Rudell and Jennifer Rudell write about the death of their son, Dr. Jack Rudell, by suicide during his final year of medical school. In their essay, the Rudells discuss their profound loss, along with their quest to prevent suicide in the medical profession by changing the culture of medicine and medical education. To talk more about how to bring about that change, I'm joined today by Dr. Lottie Dyrbye. Dr. Dyrbye is Senior Associate Dean of Faculty and Chief Wellbeing Officer at the University of Colorado School of Medicine, and she's authored an invited commentary in which she outlines a path forward. Dr. Dyrbye, welcome to the podcast.
Thanks for having me, Dr. Richman.
So you point out in your piece that many of us who practice medicine have been touched by suicide in some way, whether it's a friend, it's a colleague, or a classmate. And to begin, help us to understand the scope of the issue. How common is physician suicide and its associated factors like depression and burnout?
So unfortunately, distress in trainees and physicians is really quite common. When we go back to how were we before we even started the journey of being a medical student, we know that we were actually better off. So with that, I mean, we had lower burnout, less depression, higher quality of life than other U.S. college graduates. But then as we start to become doctors, that changes. We see higher levels of depression in both medical students and residents relative to other U.S. college graduates. We see higher prevalence of burnout, both in medical students, residents, and practicing physicians than we do in other U.S. workers, even after controlling for work hours and a variety of other things. And for some, like the story that the Rudells shared, for a variety of reasons, it culminates in really severe mental illness and at times death by suicide. The common number that's quoted is about 400 physicians die by suicide every year. Recent large studies have pointed to that women physicians, such as myself, such as you, have higher rates of death by suicide than other women in the population. And for male physicians, it's higher in comparison to other male professionals. So globally, this is a phenomenon where it does appear that trainees and physicians in practice are more vulnerable to dying by suicide than others in the population.
Thanks. That's really helpful, I think, for framing this conversation, in part because it shows us that this is not an inevitability. And so perhaps there are things we could do to alter the trajectory. So what do we know about strategies to improve wellness? We think of ourselves as evidence-based. Where is the state of the evidence in terms of improving wellness?
Yeah, so I started this research looking at first medical student and then residents, then physicians, then other members of the healthcare team, probably about, 2 decades or so ago. And when we started doing this research, there really wasn't much. There was just a little bit, some single institutional studies, a few cross-sectional kind of studies looking at the prevalence of depression and anxiety in medical students, and really very little was known. But we've come a long way. It's now been 5 years since the National Academy of Medicine consensus study was published, focusing on healthcare worker burnout and other forms of distress. And during that process of being part of the consensus study, we read over 3,000 articles, and we got lots of input from all over the country as to what was going on. And I think it's definitely well understood now that there's a high prevalence of distress in healthcare trainees and workers. And the contributing factors and the consequences, I think, have also been really delineated from big studies. And we have now also some evidence-based strategies that we can implement, right? And in fact, I think many medical schools have already done some of that, which is really great progress to see.
Where do you think the biggest gaps in evidence lie? Like, where are the big questions for the field?
Yeah, I think that the big questions for the field are really around how do you effectively intervene on culture? How do you effectively intervene in the learning and work environment? Much of the effort to date has been more focused in kind of what we think about as the individual domain. And that's very worthwhile, right? We know that, for example, mindfulness-based curriculum can be helpful for individuals who volunteer to go through that sort of training. We know that coaching and mentoring, that they're really effective and helpful strategies. But what's a little bit more difficult to tease out, right, is how do you effectively improve the learning and the learning environment? How do you turn down that stress knob so that we can get to peak performance, right? Like we know this is a stressful job, but we get too much stress, that's when we start to suffer personally, our family suffers, and the quality of care we deliver to patients suffers, right? So we need to get some more evidence about how do we dial that back effectively? What are sort of evidence-based work design, or what is evidence-based learning environment? What does that really look like?
Yeah, I think that's a really important question. As I've gone through my career, I've thought a lot about how, at its core, there is something about medicine that is inherently challenging, right? We are entrusted with our patients' health and their lives, and patients will die. Patients will have bad outcomes, and that will be distressing. Not all of that distress is bad, right? Because it means that we care about our patients and we want to improve as physicians. But of course, it can tip into a level of distress that is not helpful. And so I wanted to ask if you could reflect on that tension at the core of medicine, that we are dealing in a space that is challenging. There will be distress, but also it can be unhealthy.
Yeah, it's such a good point, right? Because medicine is hard and we see a lot of suffering in our patients and in their families. And I think in many ways, we are on board with that. What is driving the high prevalence of distress is more related to just the workload being too high, the systems that we're in being inefficient, right? The frustrations we have, we want to be at the bedside, caring for patients, examining patients, talking to families, but there's so many things that take us away from that. And that's the piece that drives a lot of this distress, that drives this chronic level of stress that we see that causes burnout. It's the struggles figuring out how to get the chemotherapy ordered in the electronic health record, right? It's the prior authorization and all the craziness around the effort we spend trying to get the right thing for our patients. In addition to that, it's things that happen within our culture, right? Here we are missing soccer practice or birthday parties, and we've totally signed up for that. But then we walk into a room and a patient refuses our care because of a visible demographic, right? Like it's those things in medicine that are really the contributing factor, much more than the moral distress piece, like this piece around, I want my patient to get better, my patient doesn't get better, or there's an adverse event. I think we knew that was going to be part of the deal. But the part that we really need to fix are the parts around the inefficiency in the work environment, the parts around what's getting in the way of academic faculty being great educators, right? It's those pieces that I think we really need to focus on.
I wanted to ask about the elevation of the notions of wellness and burnout in medical culture. There is a way in which those issues have come to the forefront, and I think they're really useful in the sense that there's perhaps, and maybe you can agree or disagree with this, but perhaps there's less stigma around some of those notions than, say, depression or suicidality. And so maybe it can be a point of entry into talking about some of those things, but at the same time, it's not quite synonymous. And so I wondered if you could reflect a little bit about what the notions of wellness and burnout encompass and what they might not, and what opportunities emerge and what might be missed.
Yeah, when we think about burnout, we really think of it as a occupational phenomenon, right? That's caused from high levels of work stress. And it's not a mental health diagnosis. There are many things that contribute to people having depression or suicidal ideation. Burnout might be one of them, but it might also be a whole other range of factors that are going on in one's life or variety of other factors. So I think that there is in our culture of medicine more recognition around this phenomenon of having symptoms of distress, right? And just starting to open that door, I think, is a huge step forward. Here we are caring for everybody, but somehow we're not able to be vulnerable and to be people and to suffer from a range of different types of distress disorders. So I don't think it's an either or kind of a picture, right? I think it's very much both. And the solutions are different. Like the solutions to people having depression are very different than the solutions to people having burnout. But both of them can have a conversation about how do we care for one another? How do we, promote a positive work environment? How do we change the things that are causing high levels of stress?
To wrap up, I wonder if you could leave us with a vision maybe for the future, either an example of positive deviance, like a system or a group that's doing it well, or even just your idea about what the future ought to look like.
Yeah, I think the future for really improving, the well-being of trainees and clinicians in the workplace is one of truly a shared responsibility. It's about me as a physician really doing the self-care, recognizing my own limits, seeking help when I need it. But it's also about maximizing my career fit, doing my darndest to be a great leader and support the next generation of physicians, right? Like working hard on being the best educator that I can be. But it's also very much that through that lens shared responsibility, it's my division chair, my department chair's role to be wellness centered leaders, to really work on reducing workload and maximizing work efficiency and promoting a positive culture. And it's about health system leaders, doing their part. And it's about deans of medical schools doing their part. I think the way that we can really make change in medicine is if we just stop othering and we start owning. We start owning that little piece of the pie, or we start owning those levers that we can push through that kind of collective action. I think we can move forward and make the healthcare workforce one of the healthiest workforce in America, so that we ultimately can deliver the very best care to our patients, advance science, nurture the next generation, all those pieces that we really deeply aspire to do.
Well, thank you so much. I am Dr. Ilana Richman, and I've been speaking with Dr. Lottie Dyrbye about strategies to improve physician and trainee wellness. If you or someone you know needs help, please reach out to someone. In the U.S., you can call, text, or chat 988, the Suicide and Crisis Lifeline. You can find a link to the article we discussed in the episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. And thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.